Wherever you are, good morning, afternoon, or evening. I'm going to talk on DFood International, a mission with vision. And DFood International is a registered international non-profit association under Belgian law. It's a DFood International is a global organization, consists of people working in the field of diabetes-related food complications. All are dedicated to providing preventive food care, and those people are spread across 7 regions. So we have Sub-Saharan Africa, South and Central America, Middle East and North Africa, the North America and Caribbean, Europe, Southeast Asia, and Western Pacific. We consist of board DFood International board members, followed by regional chairs and regional advisory. Then you have a country representative and full members across 7 regions, which I mentioned. Our mission is to promote the global profile of diabetes food prevention and care through awareness, guidance, education, research, and professional development, ending avoidable lower limb amputation due to diabetes worldwide. Our goal is to prevent and reduce the number of unnecessary amputation from diabetes worldwide and improve the quality of their lives. Our focus of action, training the healthcare professional at the primary healthcare or a village sector, because they are the people who first see these diabetic foot ulcers, how to manage diabetes-related food problems effectively and prevent amputation, giving healthcare professionals strategies to implement, develop, and sustain the food service in their own country, promoting the recognition of diabetes food specialists globally, especially in low and middle income countries, closing the gap of available and affordable diabetes food care, especially in low and middle income countries. Our activities in next 2 years, 2023 to 25, expected plan activities, which was announced on 9th of May for next 2 years. Our programs are expected plan activities during next 2 years is a flagship programs, train the food trainer courses or train the healthcare professionals step by step, and then they follow and go do it step by step in each country once they get that knowledge. World Diabetes Awareness Week, and then we have webinars like these, newsletters. There's a footwear projects, course study going on, Afro-Dial, auditing, benchmarking, launching of fast-track projects, training of surgeons and nurses. So let's talk briefly on train the food trainer courses during this 2 years term. And well, 2 of them, one was the 8th train the food trainer course was held in Saka region, and Western Pacific was also the 9th one, which had held in Kuala Lumpur, Malaysia. And these were the outcomes which we had 8 countries from South and Central America and about 14 countries in Western Pacific. Then we have almost going on, Wilma is leading in Europe region, which is the 10th train the food trainer courses or train the healthcare professional courses. And she's almost, hopefully, in February, we're doing that. MENA region is mostly concentrating on the wonton countries in Middle East, which have been deprived of this service. And then my one is the last one in Sub-Saharan Africa in Zanzibar, which is in the pipeline, and it's in the working stage of sponsors. Then we just finished with World Diabetes Awareness Week of 2023. And this is already, the dates are out for 2024, and all these are there on the website. We have brochure, we comes times to time. The first one, which was this in the series, then we came with the second one, where the goes up along the webinar. So today's webinars was promoted, and then this is the third one, which is just going to release tomorrow, and will be uploaded this evening on the website, so anybody can download it once the Robert finish his presentation, and then we'll put this third brochure in the series. Newsletters just comes before the webinars, each and every webinar. So July, September, and December, we just came out in the first week of this. And our coordinator, newsletter coordinator, should thank to her doing the great job of this. And several other projects are there. Webinar every 3 months. We have one on one Saturday between 2 to 3 Central European time, and we finished with first one with Professor Riaz Malik on diabetic peripheral neuropathy. Today is peripheral arterial disease. And these are all designed to implement international working groups consensus, which was released in May this year. So the third one is Eric is going to do, and the fourth one in wound classification. Friend Game is already here. Thank you. She's going to, and wound healing, Professor Kat. So the whole year has been set up. DFoot International website, which was promoted at the end of August, and you can see now in November is almost more than 100 people are viewing, and in November the statistic shows 3,800, more than 100 people went to the website of International DFoot International, and from 124 countries. These are all sites on the websites, and all the material, info card, brochure, project, everything, you can download it and it's free of charge. There's no problem. Then we have already set for our 8th biannual Journal Assembly and Conference, which will be held in 2025 in June. Today's webinar, total registration till this morning, Central European time at 7 a.m. We had 370 delegates from 82 countries. So here also we've made a tremendous progress on the country-wise. And now I just want to welcome all the board members, all the regional chairs, and all the regional advisory boards. Welcome as a panelist. But on top of it, we have 3 guest panelists today who are mostly on diabetic foot surgery. So Dr. Sanjay Vaidya, who is a consultant plastic diabetic foot surgeon in Mumbai, India, is a chair of organizing of 21st Diabetic Foot Society of India in collaboration with International Association of Diabetic Foot Surgeons and DFoot International. We have Dr. Rajesh Kesavan, who is a diabetic foot surgeon, special interest in podiatrists in Chennai, India. He is an organizing secretary of Diabetic Foot Society of India and board member of International Association of Diabetic Foot Surgeons. And the third one, we have Dr. Muhammad Wahid, consultant plastic surgery from Maldives. So you are welcome. Now I'm going to introduce the main speaker. I feel extremely honored and privileged to introduce our speaker for this second webinar program in our term, Professor Robert Hinchliffe. Robert is a professor of vascular surgery at the University of Bristol, Bristol Surgical Trial Center, and Bristol National Institute of Health and Care Research Biomedical Research Center. He is an academic vascular surgeon with an interest in diabetes-related complications of lower limb and minimal invasive vascular surgery. His research interest is in clinical trial and the development of new technology in surgery and their application to drive evidence-based practice for patients, mostly vascular disease. He has led health technology assessment in that field, funded trials in vascular disease, and is currently editor of British Journal of Surgery. He is a co-chair. He has co-chaired the guidelines which were released in Hague in May 2023, a development group for International Working Group of Diabetic Foot in Peripheral Arterial Disease, and he is a member of European Society of Vascular and Endovascular Surgery and Global Vascular Guidelines Group as well. So I feel extremely honored and privileged to welcome our speaker, Professor Robert Hinchliffe, for this second webinar on toe and flow, PAD, and diabetes according to the International Working Group of Diabetic Foot. So this is implementation. All the questions can be posted on Q&A section during his talk, and we'll discuss once the Robert is finished. Okay, Robert, you are welcome.
Thank you, Abbas, for the kind invitation and introduction. And hopefully, just if you could just acknowledge that you can see my slides, and then we can get started. So yes, it's a great privilege and honour to give a presentation to such an international group, and this is a really fantastic opportunity to bring together vascular surgeons, vascular specialists with the International Working Group of the Diabetic Foot. And I think that's really a clear sign, delivers a clear message that vascular surgeons and vascular specialists are really aware of both the International Working Group, it's fantastic work in this area, but also the need to get more in tune with what's happening with PAD and the diabetic foot, because as you'll see through my talk, there are some nuances related to PAD in this big group of patients. So the International Working Group of the Diabetic Foot is something that has been around now for a number of years. Nicholas Sharp and more recently Frank Game is leading that initiative. There are a number of working groups, and I'll just draw your attention to some of those as we go through the presentation. But it's important because it links a number of countries, a number of different organizations, and this is the first time that we've been able to really pull off working with the European Society of Vascular Surgery and the Society for Vascular Surgery. And I'd just like to thank and recognise all the people who've made a huge contribution, particularly to Rob Fittridge and Joe Mills, my co-chair, and very importantly, Professor Viv Shooter, who is a podiatrist, academic podiatrist from Australia. So the PAD guideline overview is one of a number of guidelines which fall under the IWGDF umbrella, including offloading, prevention, wound healing, infection, and Charcot. And you can access all of these guidelines as a free to access or free to download opportunity on the IWGDF guideline website. I just want to talk a little bit about the assessment of evidence, because clearly we were able to try to present data in a way that will hopefully provide you with some sort of insight about the potential benefits or impact for patients. So the GRADE assessment of evidence, of which we all had to do some training, provides you with a strength of recommendation, which is either strong or conditional, based on the benefits, harms, effect size, and other issues. It also gives you a review of the certainty of the evidence, either high, moderate, low, or very low, based on the underpinning research evidence. We also incorporated a number of best practice statements, and these were linked to other established guidelines, whether they're related to lipid therapy, for example, which is very relevant for patients with PAD, or the management of glycemic control, or blood pressure management, for example. So that's just to give you a sort of an understanding of the GRADE assessment, which is really quite important when you interpret what we are trying to communicate. So why is PAD important? Well, it's common, and I'll give you some data in a minute about how common it is in patients with diabetic foot disease. But as some of you will be aware, there is an important national diabetes foot audit that goes on in the UK, and these are data from a few years ago. But essentially what you can see here is that there are a number of factors that are associated with being alive and also free at 24 weeks. And there are a number of factors that are associated with having an ulcer and not being alive at 24 weeks. And the big factor there really is ischemia. So ischemia, peripheral arterial disease, is an important factor associated with bad outcomes with people with diabetes and foot ulceration. Now, clearly that's probably not modifiable, but there are some modifiable factors that are associated with bad outcomes, such as large ulceration and delayed assessment, which are important. But nevertheless, ischemia seems to be a really important factor associated with poor outcomes with diabetic foot ulceration. What about the epidemiology of PAD and diabetes? Well, actually, PAD is increasing in prevalence, and this is just not a high-income country problem. It's also prevalent, particularly in low and middle-income countries, and becoming increasingly so, perhaps related in large part to smoking habits and changing diet. And particularly in older age groups, so obviously PAD more prevalent in older age groups, and in low and middle income countries, I guess probably slightly more surprisingly, women have a higher prevalence than men. So this is just not a problem of male sex and age, it's also a problem of women, particularly in the low and middle income countries. But the other really important factor, and this is really important for diabetes, is that diabetes has the strongest association with a new presentation of chronic limb-threatening ischemia. So there's clearly a range of peripheral arterial disease from being asymptomatic to minimally asymptomatic with claudication. But patients with diabetes are more likely to present with chronic limb-threatening ischemia, and that's a big driver of that. So in terms of the clinical guidelines, we've tried to incorporate all aspects of care from the diagnosis to the prognosis and to the therapy. And clearly we have some limitations in terms of the underpinning evidence, but I think that's really really important, because this is a great opportunity to dissect the evidence as it is, but also try and provide some clear guidance for both healthcare professionals and patients who may well have peripheral arterial disease. So how does PAD fit into diabetic foot ulceration? I think these are the questions that are going through my mind when I'm approaching a patient who may well have PAD. I think the first question is whether does this patient actually have PAD? And when we were setting up our PICOs, our very clear sort of hypotheses or statements about peripheral arterial disease and diabetic foot disease, we tried to sort of put ourselves in the position of a healthcare professional looking after a patient with diabetic foot ulceration. So the first question that really went through our minds was, does this patient have PAD? I think the second thing is to recognize that PAD is associated with a very high cardiovascular event rate and low long-term survival. So what's going through my mind is can I actually improve this patient's overall cardiovascular risk profile, and can I improve their overall survival? And we shouldn't lose sight of that. A lot of these patients will die of a heart attack or a stroke, and not actually of their foot ulcer or their peripheral arterial disease per se. The other thing going through my mind is, well, is this peripheral arterial disease sufficiently severe to be impairing healing? And is it likely to result in amputation? And that might seem slightly perverse, but actually there are many patients, and about half of patients with diabetic foot ulceration and PAD about half of patients with diabetic foot ulceration will have PAD, but I'm not sure that all of those have PAD, which is actually impairing wound healing. I think the other thing you need to be aware of is whether there are additional interventions that can optimize healing, and that's relevant because you don't want to spend all your time doing very lengthy, complex, expensive procedures with significant adverse event rates, when actually it's probably more appropriate to improve a patient's offloading. So you shouldn't neglect all of the other evidence-based interventions to improve a patient's healing. And then I suppose finally is, can we actually improve healing and prevent amputation with revascularization? For some patients, revascularization may be too late, and for other patients may well not be necessary, or actually so prohibitively risky that you're not going to benefit the patient. And the final thing that goes through my mind is, well, if revascularization is required, what is the best technique? And I put that very much at the bottom of the list, because I think for far too long, vascular specialists have worried far too much about this. And actually, there are so many more issues related to PAD and the diabetic foot, which are actually much more important. compared to sort of arguments about whether people should be using angioplasty or bypass, or whether they should be doing drug-eluting angioplasty or whatever. So there are a number of kind of key considerations why we actually developed the guidelines, because PAD is slightly different in people with diabetes and diabetic foot ulceration. You don't often get the classical symptoms of PAD in diabetes, of claudication particularly, often related to the neuropathy and the distal distribution of arterial disease. It's difficult to diagnose because of the lack of classical symptoms, but also the presence of medial arterial calcification in many patients, which make arteries difficult to compress, and therefore some of the tests, as we'll go into, more difficult to perform and interpret. I think you should also be aware that many of the tests and treatments are really not perfect. They're infallible and often not definitive. Decision-making is imperfect and complex. And we'll provide some guidance, but clearly in individual patients, it's important to involve them in their decision-making. This is a shared decision-making exercise. What we should try to do is provide patients with as much information as possible for them to be very much more involved in their decision-making. And I think finally, I think you have to recognize that there are regional differences in delivery and care, and that's really important. But I don't think we should really be in a position where we can't be able to offer all aspects of peripheral arterial disease interventions for most patients. So why diagnose peripheral arterial disease in people with diabetes? And what is peripheral arterial disease? Actually, if you look in textbooks and papers, it's actually very difficult to find a very clear definition of peripheral arterial disease. But the way in which we defined it was that it was the presence of any objective atherosclerotic disease from the aorta to the foot, associated with clinical signs or abnormalities resulting in disturbed or impaired circulation. And in the diabetes population, that's present in about a quarter of patients and about half of patients with foot ulceration. And we are very much focused on those with diabetic foot ulceration in this guideline. So in terms of the diagnostics then, is there any relevance? Is clinical examination a complete waste of time when we've really got some very sophisticated tests? Well, actually, it probably isn't. Foot signs of ischemia and palpation of foot pulses and clinical evaluation is part of a series of assessments and investigations, and we shouldn't neglect that. So I think moving straight towards high-cost tests and investigations is probably inappropriate. And in every patient, there should be a relevant history taken for PAD, and foot pulses should be examined, and the status of the feet should be examined. What about the benefit or otherwise of non-invasive bedside tests? And by that, I mean things like ankle brachial pressure index, toe brachial index, and Doppler waveforms. Well, actually, in isolation, none of them are perfect, but it does seem that ankle brachial index, from the evidence that exists in the current literature, and toe brachial index and triphasic and biphasic pedal waveforms are good tests to help us confirm or diagnose PAD and potentially exclude PAD. But as I'll explain in a minute, there are some limitations. In terms of the sort of algorithm that you might want to adopt in terms of the diagnostics, I think the first thing to do is to consider in a patient with diabetes, foot ulcer and gangrene is to actually palpate the pulses and examine for signs of ischemia. It's important to evaluate pedal Doppler waveforms and perform an ABI and TBI. And now I think it's actually very difficult to justify the management of these patients without being able to perform those non-invasive tests and be aware of their limitations. In terms of what other things you should be doing, wound care and offloading is really important. as is the assessment of presence and management of infection. And all of those can be guided by the International Working Group of the Diabetic Foot Guidelines. In terms of the interpretation of ankle brachial index, now clearly there are two major arteries traditionally that one makes an assessment of the ankle brachial index, and that's usually from the posterior tibial artery of the ankle or the anterior tibial dorsalis pedis artery. And the traditional method has always been to take the higher ankle pressure as the numerator and the higher brachial pressure as the denominator. An alternative method is to assess with the lower ankle pressure and the high brachial pressure. And there are pros and cons of either of those, but what you have to be aware of is that there are differences in terms of the interpretation of those results. Again, this comes into the sort of the mix of really fully understanding what the limitations of these techniques are. In terms of making diagnostic assessments, then we've used the likelihood ratios, and the likelihood ratios is something that we've used a number of times over the years with the International Working Group of the Diabetic Foot in terms of interpretation of diagnostic tests. It's just to say really that the higher the positive likelihood ratio, the greater the ability of the test to rule out the outcome of interest, to rule in the outcome of interest, and the smaller negative likelihood ratio reflects better the ability of the test to rule out the outcome. So in this case, positive likelihood ratio to diagnose PAD, and a negative likelihood ratio to be able to exclude PAD. And a positive likelihood ratio of 1 means that the test does not change the probability of the outcome over and above the pre-test probability. So therefore, the diagnostic test is actually not helpful. And in clinical practice, actually positive likelihood ratios around 10 are very helpful, and negative likelihood ratios of 0.1 are very helpful. So what about the diagnostic bedside tests and how do they perform? Well, actually they perform differently according to whether the patients have diabetic foot ulceration or not. And as you can see here within these tests, so on the side of the screen, you've got ankle brachial index, ankle pressure, toe brachial index, toe pressure, and transcutaneous oxygen. Different studies have used different thresholds, and there is a range of diagnostic ability reported by each of those studies, and therein lies part of the problem, in that none of these tests are perfect, and all of them have limitations depending on which studies are presented and which group of patients that you're focusing on. Suffice to say that we think that on balance that these tests are helpful, probably in combination, but none of them are perfect, and you have to be aware of their limitations. So trying to interpret or synthesize all of that quite disparate evidence and relatively low quality evidence, I think it's fair to say we came to a conclusion that a low ankle pressure, less than 50, was associated with a greater likelihood of impairment of healing and a greater likelihood of major amputation, and that really makes sense. And toe pressures greater than 30, greater than or equal to 30, increase the pretest probability of healing by up to 30%, and increase the ability of these tests to identify patients at higher risk of major amputation if they're less than 30. And the same with TCPO2, greater than or equal to 25, increases the pretest probability very significantly of healing, and less than 25 increases the pretest probability of ending up with a major amputation. Skin perfusion pressure may be even better, but the amount of evidence to underpin that probably comes from a single study and isn't widely used, particularly in Western Europe. What about the prognostics of bedside testing then? So not only the diagnostics, but also the prognostics. well, actually, again, you can see quite a range of prognostic value of each of these tests. And part of the problem here, of course, is that, as I've alluded to before, peripheral arterial disease doesn't exist in isolation. It's often in combination with an infection, a different size of a wound, a more or less sick patient. So it's very difficult to interpret in isolation the value of these tests, but we've tried to synthesize that for you. But this just gives you a sense of the range of these values and how useful they may be in clinical practice. And the difficulty, of course, in interpreting many of these bedside tests is that they're influenced by many factors. So if a patient's been smoking, if the patient's just come in from the cold outside, if the patient's, it's dependent on patient position, dependent on calcification, there's some inter-observer variability. So there are sources of error here, and these are the things that actually, if you read the International Working Group of the Diabetic Foot and Inter-Society document guidelines, you'll see the limitations. These are the things that you should be aware of, and that's why, in a sense, all of these tests need to be taken with they're often better in combination, and they're better when you take into consideration other factors in the patient's management as well, and I'll explain that in a few minutes as well. So in terms of how you should classify these patients, is there benefit for a classification of these patients? Well, we'll probably be hearing about classification systems in the next few months anyway, but we would recommend the use of the Wi-Fi classification system. It's helpful in terms of estimating healing likelihood and amputation risk. And certainly locally within our own unit has been helpful in terms of getting people to think about patients in a logical way. And it's very helpful when you discuss patients in an MDT to be able to explain to other healthcare professionals in a sort of standardized fashion what sort of patient you're talking about. What is this patient in front of you? What sort of problems have they got? And that helps a great deal in terms of standardization of management within individual units as well. So just in brief, the Wi-Fi system incorporates various components, so wound, ischemia, and foot infection, and the wound grade goes up with increasing severity of wound, and the worse the perfusion deficit, the higher the grade. So those with a really low toe pressure have grade 3. Those effectively with no ischemia or no evidence of ischemia have a grade 0. And those, again, with more severe infections have a higher grade. And then you have a classification system where you can actually convert each of those component parts of the Wi-Fi classification into 4 clinical stages. And obviously the risk of amputation is higher with the higher clinical stages. And so within our wall, in our own department, for example, we have a Wi-Fi classification system, and people can actually generate the potential for risk of amputation at 1 year, from very low, which is clinical stage 1, through to high, which is clinical stage 4. And of course, there's also potential for estimated likelihood of benefit from revascularization. So, for example, if you have a wound grade 3, foot infection grade 3, and ischemia grade 3, then you're high clinical stage 4 with a high likelihood of benefit from revascularization. You can actually, so the Society for Vascular Surgery have an app which you can plug all of these individual components into, which will actually generate your Wi-Fi classification with amputation risk and potential for revascularization benefit. And that's actually quite an easy way of trying to synthesize that information using that app. Is it helpful in terms of prognostication? Well, there is increasing evidence that it probably does provide additional insights into wound healing. And the relatively recent paper from Penner et al. In 2021 would suggest that as you increase your Wi-Fi stage from 1 to 4, your cumulative incidence of wound healing decreases. So a higher Wi-Fi stage is associated with lower incidence of wound healing. And that's by quite a significant hazard of risk. And in terms of your major amputation risk, as you increase your Wi-Fi stage, then your major amputation risk increases. So for every unit of Wi-Fi stage in that particular study, the hazard of major amputation increased by nearly almost 3 times. In terms of the overall referral, I think we were very aware that there are regional geographic differences and different healthcare differences to referral pathways and assessment by different healthcare professionals. But I think we all have a responsibility to be able to identify ischemia and refer appropriately. And we struggled a lot with this, but essentially what you see here is that I think it's everyone's responsibility. The sort of nub of this is that those patients with the most severe ischemia clearly need to be prioritized. In essence, an urgent consultation by a vascular specialist should really focus, if at all possible, on those with the most severe forms of peripheral arterial disease. So those with low toe pressures, low ABPIs, and low TCPO2s. Urgent revascularization should be considered. Those patients with gangrene, particularly urgent vascular specialists, should be reviewing those patients. And then there are a group of patients who clearly don't have peripheral arterial disease, and then a group of patients with a relatively modest perfusion deficit, where actually it's important to reassess the perfusion over a matter of weeks. And this goes back to the notion that none of these tests in terms of perfusion assessment are absolutely perfect. And that's why it's important never to make a single decision and not to readjust that decision based on how the patient is doing. If you've optimized all aspects of a patient's care and they're really not improving over a period of 4 to 6 weeks, then it's important to reassess the perfusion and think, actually, does this patient have significant peripheral arterial disease that we're not aware of? Are the tests spuriously high, for example, because of medial arterial calcification? And does this patient actually require revascularization? What about other investigations? Well, I think things like CT angiography, MR angiography, and digital subtraction angiography are important in the management pathway, but really they're only in maps. They don't, for me at least, make a great deal of difference in terms of decision about the need for revascularization. They may tell you it's very difficult to revascularize a patient, but they don't tell you anything about whether a revascularization should be considered. So they should be just seen as roadmaps, really, I think, and that's important. And in terms of revascularization options, then, there's been we've been quite blessed in vascular surgery, I suppose, that we've had the BEST CLI randomized clinical trial, and also the Basel studies, which have been really quite influential in terms of our thinking about these group of patients, and particularly the BEST CLI study, which is a very large study comparing open and endovascular revascularization, which would seem to suggest in all patients and in the diabetic subgroups that there is a benefit from bypass operations if you have a good conduit with a great venous vein to perform that revascularization. And in terms of patients who don't have that great venous vein conduit, then there's probably not much to choose between using an alternate conduit and an angioplasty approach. I'm going to talk a little bit about angiosomes, but that's not, I think that's probably a relatively small print for most people managing the diabetic foot. It's probably of interest to vascular specialists more. So just to tell you a little bit about the BEST CLI trial, which was led from the US, but incorporated in a number of centers outside of the US, is really important trial led by Matt Maynard and Alec Farber, and they randomized patients in 2 separate cohorts, almost 1,500 patients in the first cohort and then 400 in the second cohort. In the first cohort, they compared angioplasty procedures with bypass procedures where you had a good great venous vein to perform the bypass. And in the second cohort, it was where the patients didn't have an alternative conduit, which is probably somewhere in the region of a quarter of these patients. And then over a period of time, 2.7 years in the first cohort and almost 2 years in the second cohort, outcomes were measured. And what they found was that, in essence, focusing on the diabetes cohort, that there was a benefit in terms of a reduction in major adverse limb events or death and major amputation and reintervention by almost a third in the first cohort with diabetes. But there was very little difference between bypass and angioplasty, where you didn't have a very good great venous vein to perform the bypass procedure. Just dwell a little on angiosomes. This is really maybe we can talk a little bit more about this in the discussion. This is really a plastic surgery concept in which arteries in the body provide blood supply to blocks of tissue, and in the foot there are 6 angiosomes coming from the 3 major arteries. So 3 angiosomes coming from the posterior tibial artery, 2 from the peroneal and 1 from the anterior tibial. What the data at the moment would seem to suggest from some very small studies, which are potentially high risk of bias, is that if you can at all revascularize either with angioplasty or bypass the artery which is supplying the area of the foot with tissue loss, then that is to be favored and may well improve healing compared to revascularization of an artery or an angiosome which is away from the area of healing. But the data is really very difficult to interpret at the moment. But I think we felt it was sufficiently strong to be able to suggest, if at all possible, that you should try and revascularize an area of the foot with using an artery supplying that where the tissue loss exists. So what about best medical therapy? As I alluded to before, a large number of these patients with peripheral arterial disease and diabetes die because of cardiovascular reasons, particularly heart attacks and strokes. We shouldn't really underplay the importance of the optimization of these therapies. And I think it goes some way to underscore the importance of working within teams. So if you as a vascular specialist, for example, are not confident in managing or haven't received training in managing these aspects of medical care, you need to work within teams of people who are confident in managing these aspects of care. So these are really important. So the optimization of HbA1c, blood pressure, lipids, and antithrombotic agents, all of which are really important. And there are guidelines within the Inter-Society guidelines to be able to help you deliver on all of those aspects of care. So I think in conclusion, PAD is highly prevalent, and around half of patients with a diabetic foot ulcer will have PAD, and it's associated and it's necessarily associated with poor outcomes. And therefore, I think we should all be familiar with the investigations which are relevant to the diagnosis and exclusion of PAD. And also we should all be aware, whether you're a vascular specialist or not, about the limitations of some of those tests to identify or exclude PAD. I think it's important that we recognise that those at highest risk of adverse outcomes require identification. And that's why the Wi-Fi system is actually quite a helpful classification system to be able to identify those at highest risk and those who are likely to be highest risk of amputation, but also those who are most likely to benefit from revascularization. These also important that patients with PAD are managed holistically, and that we don't focus, which I think has been an error in the past, particularly from vascular specialists, and to ignore other aspects of diabetic foot ulcer care. And it's important to use evidence-based interventions, whether you're talking about offloading or wound healing, to manage these patients. And I think it's important that we also recognise that this group of patients require comprehensive cardiovascular risk reduction to make them live longer and to reduce the burden of cardiovascular events, which are very significant indeed. So finally, I'd just like to draw your attention to the clinical practice guideline documents, which you've already seen are present on the IWGDF guideline website, but also published within the European Journal of Vascular and Endovascular Surgery, Journal of Vascular Surgery, and Diabetes and Metabolism Research and Reviews. And finally, I'd just like to acknowledge, as I did at the outset, all of the important work done by many of these interprofessional groups and specialists. And with that, I'll conclude. Thank you very much.
Thank you very much, Robert. Thank you for a perfect, to the point, and very clear talk. I think everybody must have enjoyed it. It was an excellent talk. Okay, it's open for question and answer. I have here with the questions, 2 questions which have come here. Your advice on managing patients with diabetic foot wounds and palpable pulses, but poor bleeding in the toes, microvascular disease. What is your advice?
I think we all feel reassured when we can palpate pedal pulses, but I think it's pretty clear from the evidence that it's not entirely reliable method of excluding peripheral arterial disease. So I would feel that it's not reasonable to manage patients just with the with clinical examination anymore. I think that's pretty clear from the guidelines and from the underpinning evidence. In terms of microvascular disease, it's a hugely controversial topic, but I think we've made a pretty clear statement that microvascular disease should not be blamed for any healing problems. And, I think certainly in the UK, at least, that's something that has almost been something that people talked about for a number of years. Oh, well, this patient with diabetes is not healing because they have microvascular disease. I think that's incorrect. And should be avoided in terms of a concept.
Yeah. Can you hear me? I think you can hear me. Eh?
Yeah.
Hello. Yeah. Any advice? There's another question, then we'll go to the panelists. Any advice on how to manage a patient with PAD and foot gangrene without vascular surgeons? And that is very common in most of the low and middle income countries.
Yes, and I think as I showed, the data from across the world would suggest that PAD is an increasing problem, particularly in lower middle income countries. And I suspect we are probably going to be seeing an increased number of amputations as a result of that. I think that's that really is an opportunity for DFOT International to work with collaborators to be able to deliver training in those areas. I think that a lot of the interventions that we do, unfortunately, vascular, are expensive, but a lot of the interventions are probably relatively untested. So a lot of the really complex endovascular technologies probably can actually be relatively straightforwardly delivered with more straightforward, less expensive technologies. So I think with training, it's going to be feasible to deliver a lot of vascular surgery and a lot of vascular interventions. I think it's probably going to be all about education. And now we recognise this problem, it's going to be something that societies, DFOT International, are going to have to try to address.
Thank you, Robert. Dr. Shakawi, you have a hand.
Yes, I'm here.
Yeah. My internet is giving a problem, so I've off my video. But Dr. Shakawi, I can see your hands. Yeah.
Okay. Really, thank you very much, Professor, for the best lecture about the PAD and in diabetic patients. And it's very important, I think, for all attendants all over the world who are not vascular surgeons to know that there are 5 important risk factors or etiological factors that will push to limb loss if you didn't diagnose them first on the first look of examination and assessment. One of them is the peripheral arterial disease, which constitute 20% of cases, and 80% will have something else. For example, we are caring for blood quantity, which is the peripheral arterial disease, but there is something called blood quality factor. Blood quality factor is present and diagnosed in our study, which is published, in 80% of cases. And if you correct the peripheral arterial disease without correcting the blood quality, which is, as example, serum albumin very low, hemoglobin low, patient is dehydrated, something like that, the patient will have amputation. Also, the bone factor, which is important, constitute 33.5% of the etiological factor for limb loss if not diagnosed well. And so it's very important first for everybody to diagnose the etiological factors, the risk factors for limb loss first, then to treat each one separate. As regard the strategy after that, after diagnosis, it depends on what is present. For example, I can treat the blood quality, so the peripheral arterial disease will not be significant much, and maybe I will not do endovascular intervention or bypass, and this will be sufficient for correction of the problem of the patient and to save the limb. This is a point. Many other points, but I want to comment also on the microvascular problem. Really, it's a hanger in the OR or in the endovascular suite. When we fail, we look at the hanger, we say, oh, the microvascular, the patient have microvascular disease, diabetic microangiopathy, that let us fail. And when we succeed, we ignore it and look to the other side and everything is perfect. And so, as the professor said, microvascular disease is something imaginary more than something to touch and to treat and to make of value for that. the incidence of 3 factors together at an etiology for limb loss of a patient with diabetic foot lesion, the incidence is 80% to have more than 2 factors together. And 2 factors only was 20%. And 1 factor only was 0. This is in a study over 5,000 cases of diabetic foot lesions. And so I think it's very important, very vital, first, to diagnose the etiological factors that may lead you to have limb loss. Then to do the strategy of management, which first, and then to manage, hope this will succeed to prevent avoidable amputation. Thank you, sir.
Thank you, Dr. Shakari. Thank you. Robert, you want to comment, or should we move to another question?
No, let's move to another question, I think.
Okay. Yeah, that was more of comments. Thank you, Dr. Shakari. Yes, Milan, your hand is up.
Yeah, good evening to all of you. A very nice, informative lecture by Dr. Robert. I really appreciate and for giving this to DFoot International. So my question is, my colleagues from India would agree that in district places or not in tertiary hospitals, we mostly do endovascular revascularization instead of bypass. Maybe because of the technical problem, or most of our diseases are below the knee. So when we do this, as a surgeon, I would like to ask you, if you do an endovascular procedure where we mostly do dilatation, a balloon dilatation, what is the period that we look that it doesn't recur back, or we have a window period to heal the wound?
Yeah, I mean, I think you make a good point. The guidance has changed somewhat now, in that before, I think, like going back to the sort of 2018-19 guidelines, we were much more of the opinion that you should assess success very much based on clinical assessment. Was the wound, usually the wound healing? And I think, you know, that still is incredibly important, but probably now there's a sort of recognition that some of these factors like toe pressure, TCPO2, can be helpful to kind of inform the potential benefit earlier and identify patients who are going to benefit earlier. So the data is not great. But certainly, if you're doing a distal angioplasty and don't see any improvement in toe pressure or TCPO2 very early on, then that's probably an indication that the patient is not going to benefit from that intervention. And you often see that with, for example, perineal angioplasty. So that perhaps gives you an earlier indication rather than waiting 4 to 6 weeks to see whether the wound starts to heal or not. So there's a degree of clinical judgment within that, but I think now we sort of would suggest that non-invasive bedside tests can be used in combination with clinical assessment to see whether these things can benefit.
Thank you.
Okay, thank you. Yes, Linda, you are next. You're mute, Linda.
Yeah. Well, first, thank you very much, Robert, for a very impressive talk. And I think I have already spread it here in Saka, and I'm sure it will be very useful for everybody. Just some clinical comments. I'm a doctorologist, not a surgeon. I noticed that you presented the use of SGLT2 inhibitors when the GFR is above 30, but in fact, and also I say that because there's a way of motivating people to use more this class among people with diabetes and peripheral arterial disease, that Cadigo, in about 2 years ago, has already set up a lower GFR, like 20 or more ml per minute. And I think this is very, very important to say, because there are still many people who are afraid of using these drugs because of the former and equivocal data on amputations. And the other comment that I would like to say is that you are very quite right to say that peripheral arterial disease should not be an excuse for not healing houses, but unfortunately, in developing countries, because of the access is so low, unfortunately, infection and also the arterial disease is still a very important player against healing. And I wonder how we could try to manage to have something more accessible in our countries, and especially those that have lower resource to have these problems circumvented.
Yeah, I mean, Linda, you raised some important issues. And of course, I think now toe pressure machines, for example, are a lot cheaper than they used to be. And let's put this into some sort of context. Most of these patients, certainly in many countries, are coming back for lots of assessments, and it would strike me in the greater scheme of things that actually a toe pressure machine of of the region of low sort of hundreds of dollars is probably somewhat cheaper than multiple treatments, amputations, etc. So I think you need to be, or one needs to be aware of how that sort of technology can help, because I don't think they're prohibitively expensive. They're certainly a lot cheaper than a lot of the stents and things that we use in the in high income countries, and I think they're going to be a lot cheaper than trying to rehabilitate or provide prostheses for people with amputations. So I don't think they're so prohibitively expensive anymore. I mean, I think things like TCPO2, skin perfusion pressure, that's a slightly different kettle of fish, but I think these other things like toe pressures now, some of the machines are relatively cheap.
Thank you very much.
Thank you. Thank you. Yes, Dr. Mohammed, your hand is up. Dr. Mohammed,
Yeah, hope you can hear me.
Yeah.
Thank you very much. I appreciate a very informative lecture by Professor Robert. Just want to add here, we in the Maldives, we also one of the resource-lack country. So our geography, we have many islands. One of the referral criteria for the patients from periphery hospitals, we rely on peripheral pulses. So that is one of our referral criteria, because we have been noticing that late referrals, late referrals end up in amputations in most of the cases. So we keep especially dorsalis pedis pulses and posterior tibial pulses when it is absent. One of the referral criteria, because we don't have even ankle brachial index to be measured in these periphery hospitals, as well as the toe pressure. So that is one thing I would like to mention. And I have one question for you. Is there any role of venous arterialization in peripheral arterial disease or in diabetic foot?
Yeah, Mohammed, I think you will save many more feet and limbs with standardization of your pathway and incorporation of things like toe pressure than you will save using venous arterialization. I think the venous arterialization is incredibly expensive, and I think the data to suggest that it's effective in the 20% of patients who you can't revascularize is still not strong. And so I think it may be a bit player in a very small percentage of patients, and I think the data is still not sufficiently robust. But I think, you know, the advantage of working with DFOT International in the international working group is to be able to take these guidelines and to be able to leverage support for evidence-based interventions. And we're not talking about incredibly expensive things. And we're aware of that. But, you know, if you take those guidelines, you can potentially leverage support of those things that will save amputation. So presumably for the Maldives, any patient who has an amputation will be hugely expensive. But if you want to try and reduce amputation rates, then by incorporating things that we know work, will potentially save money as well. So I think you could potentially, use these as a leverage with your own health ministry or healthcare providers to be able to deliver these interventions.
Thank you. I can see two more hands. Maybe Dr. Sanjay, you can start, and then followed by Dr. Shakal.
Thank you, Dr. Robert. It was an excellent lecture. In cases where you have infected diabetic foot ulcer or a gangrene where revascularization is not possible, in such cases, what do you think is the role of stem cells procured from adult healthy volunteers and injected in the calf muscles as well as around the gangrene and the peri-wound area? Do you think it's a useful modality?
Sorry, Sanjay, I didn't catch that.
Stem cells therapy in cases where
stem cell therapy, yeah. I think there's been a lot of effort put in by vascular specialists for a number of years trying to identify therapies, growth factors, stem cells, and other treatments to improve the outcomes of that difficult group of patients. And still, there isn't really, from my interpretation, I think also from the guidelines group, of much convincing data. There are some preliminary studies, small studies, which would suggest that some of the surrogate outcomes, so things like improvements in transcutaneous oxygen might be better, but in terms of hard clinical outcomes, I think we're still lacking evidence of benefit from things like stem cells. So yeah, I think we should keep an eye out for high quality studies, but at the moment I think they're lacking, and also incredibly expensive and difficult to develop.
Thank you, Robert. Yes, Dr. Shakal.
Yes, I want just to comment about the question that was raised about the value of PTA for the diabetic foot ulcer healing. Actually, PTA, especially infrapopliteal arterial disease PTA, will give a very good chance and window to heal the ulcer, provided that two things. Number one, the PTA is done good, which means there is no overdilatation of the artery. If it was 90%, we can make it 40% stenosis, and this is enough. Number two, which is more important, is that other factors for wound healing were corrected first in the foot. Then the vascularization will help. And this will help at least from 6 to 8 months. This is the shortest time that, and after that, if occlusion happened again after healing, there will not be recurrence again. Of course, the patient will have healed wound and there is no recurrence, and the collaterals can feed the foot, provided that other factors are treated. Thank you.
Thank you, Dr. Shakal. Robert, we're running out of time, but there's a last question. Let me put this question. I've been asked this, where those arterial investigation tools less expensive could be found. This information would be very valuable for low and middle income countries.
Yeah, I mean, there are really expensive toe pressure machines and using things like laser Doppler, and then there are less expensive toe pressure machines which are also perfectly good. Ankle brachial pressure index is relatively straightforward. You need a handheld Doppler, and so things like handheld Dopplers, some of the toe pressure machines are a lot cheaper than others. But as I tried to explain earlier, amputation is also very expensive as well. So yes, I understand that there's a sort of financial outlay, resource outlay to these tests, but I think what we've heard over a number of years is that particularly from lower middle income countries, is not to adjust the guidelines to be suboptimal, for want of a better term, for patients in lower middle income countries, because we've heard a number of times that we or people can use the guidelines to leverage these resources from their health systems. So I think it's probably a matter of trying to discuss the benefits of these interventions, which I think are significant. And I think it would be very difficult in the modern day and age to manage these patients without some sort of non-invasive investigations, and nigh on impossible.
Thank you very much. Thank you very much. And we have actually gone 15 minutes over. So the interest, you can see, all good things have to come to end. I will now pass on to my President, Professor Harry, to give you a vote of thanks. Harry? He seems to be not there. Okay. Anyhow, we would like to thank you, Prof. Robert, for this. You took a time from your busy schedule, accepted the invitation to talk on a live webinar. Robert, thank you very much indeed from bottom of my left ventricle. I would also like to thank all the board members, DFoot International's regional chairs, regional advisory of DFoot International, for working hard to get this program running smoothly globally over 7 regions. Special thanks to the core team of this diabetic foot webinar education program, for the Secretariat, IT service provided in the Secretary of DFoot International. All, big thanks to all of you. And finally, I would like to thank all the delegates who have participated, because without them, no webinar is successful or possible. So a very big thank you to all of you. Thank you very much.
Thank you. Bye-bye.
Thank you. Take care. Bye-bye.
Thank you. Bye-bye.